share screen for everybody. All right, wonderful. As always, we'll send out the slides afterwards. So if you don't catch something, it'll be in the email. Reminder, closed captions are available via Zoom, and here are some instructions for how you can make that happen. We'll go to the next slide, and if you have questions, Ellie and Olivia can, actually, Ellie will help you out over chat. Reminder of who the steering committee are. You'll see probably several of us in the Zoom chat today. These are the folks who are, figuring out what we want to focus on in the seminars and where we want to go next. So you can reach out to any of us to talk about anything that you have for future directions and ideas. Next slide. As a reminder for all of you, we are one network that is funded by NIDA to advance the science on recovery community centers. And while we were funded to do this, other teams in other parts of the country were also funded to advance the science on recovery support services. And they had a different emphasis in different areas, rounding out the whole picture. And after funding, all of us got together and we created the Consortium on Addiction Recovery Science with support from NIDA. And we have this slide in here, and it's fine print, and you won't be able to read it all, but it's going to be in the email of upcoming things in case you wanted to participate in community boards, or you have a young scholar who wants to start getting training and mentoring, or there's a cool publications that have come out, or there's other webinars. That's why we circulate these things for all of you. What I want to highlight is an online conference. It's going to be the first national conference on addiction recovery science. It's going to be happening on April 24 and 25th. I think several of you are already presenters there from people who are in the room today. And I hope that the rest of you will take a peek to see if you might join and come to this conference. It's online, so hopefully easily available to everybody. All right, next slide. For ongoing lists, so we're keeping a list of all the RCCs. When we did our nationwide survey, we identified about 200. That number has gone up by a lot, is my understanding. Certainly Massachusetts and some other states I could name. We're trying to keep a list of all of them. So if you know of RCCs that are new, or you know of a new statewide coordinator who could give us an updated list, we would absolutely love it. People reach out to us and ask, is there an RCC near me? And we hope to give them lists that are up to date. So if you have of RCCs to tell us about, please do. Since I mentioned the study on our nationwide survey, we mentioned the results. We've shared the results of that survey with you before. That paper is finally out in the Journal of Addiction Medicine. It's public access, so anybody can actually read the real version of it. And we have a link here. So please, if it's helpful to you guys, I hope you will enjoy reading the paper. I hope it's useful when you need to tell other people about recovery community centers and related issues with that. We hope it's a useful reference for you all in your work. So I think Ellie put the link into the chat as well, so that you can just click on that, download the PDF, and of course, as always, happy to answer questions or help further with any of that. All right, so I covered the RCCs, if you can do that. Oh, and then the other thing. Ellie, if you can also put the link for our upcoming seminar, in case you haven't registered for April yet, please do that too. So we are good to go on that, because we put on our last slide always, and then we always get into the discussion and we always forget to actually share that screen. All right, so much for logistics. Off to the fun part of our live feature. As you know, we always ground ourselves in the actual experience of an RCC. We're really happy to have Elise Holm with us today, who's going to tell us about her RCC. So Elise, can you take it away and tell us what happens when you walk through the door of your RCC?
Thank you, Bettina. It's so great to be here today. I hope everybody's doing well today. So the Healing House is a transitional living facility or program for people in substance use recovery. So when we talk about our RCC, it is difficult to talk about it without talking about the program that is kind of linked to. So a large part of the participation in our program is linked to the program that we have called the Healing House, which houses about 190 people. So when any of those people or people in the community come to our RCC to engage in programming, we tell them immediately, welcome home. Because that comes from a lot of people that come in here have broken homes, or they don't have they have a broken sense of what home was. And so we want to welcome them into the safety of what we do here. So anybody that comes in is probably largely going to be participating in the transitional living. So we welcome them home and immediately just get them, begin to assess where they're at in their recovery and what services and resources we can offer them to help them in their journey. So everybody that works at this RCC is a CEAP certified peer specialist, and it is actually a peer run organization. We assess their current state, what do they have? Some people come in from prisons, some people come in from the streets, some people come in with a lot of things, some people come in with nothing. So we help them get clothing, hygiene products. We set them down and kind of assess if they need help getting an ID, a social security card, a birth certificate. Do they need to get signed up for Medicaid? Do they need food stamps? Do they need linkage to medical care? And we work with community partners to make sure that they can get on MAT services if that's necessary for them. We also work with other community partners to assess if they need detox. So we are able to funnel the resources that we have to be able to connect them with the right care that they have. So if they're going into the transitional living portion of the housing, then we get them access to recovery support service, a voucher for funding. And even if they're going somewhere else, we give them the resources to help them figure out, to help them with the funding as well. So on the day-to-day here, they have access to life skills classes, relapse prevention, thinking errors. They get enrolled in outpatient services. Also, and access to counseling and recovery coaches, parenting classes, recovery groups like AA, NA, Smart Recovery. And then also if they have needs to go to doctor's appointments or they're on probation or parole, we have transportation actually that is able to drive them to those places in the community as well. They also eat here at this RCC, and we serve about an average of 5,000 meals a month. And one of the highlights that we like to celebrate on Friday nights, where we can celebrate people's recovery, where they give their testimonies and share about their experience, strength, and hope. And man, like this RCC really, and it really changed my life too. So there's a lot that we do at this RCC. There's a lot of events and sober fun that we have, and just trying to be a safe place in the community for people to come receive resources, support, housing, and linkage to services, and whatever else we can be. And we understand that we can't be everything, so we definitely highlight working with community partners and how we can reach more people by working together. So that's a little bit about the Healing House. I thank you so much for the opportunity, and I'll give it back to you, Bettina. Thanks.
Awesome. Thank you, Lise. And you set us perfectly for April, because in April, we're really going to be talking about how do RCCs do outreach? Like, how does that all work, that you're so well connected to everybody around you, and how you get people together around that mission of providing support throughout recovery. So thank you for that plug.
Wonderful. Yes.
All right. Perfect. Thanks, Elise. All right, Olivia, if you can move us forward. All right, as you know, the next piece is going to be the polling questions. This is going to be including, and you can go ahead and start it already while I talk you through it. The idea is simply that we want to keep track of who's in the room. Our goal here is to bring together the multiple stakeholder groups and to have actual discussion amongst us and learn from each other. That's why we always ask who you are and where you're from, so that we can look who's missing and who we can integrate into the conversation, so that we can really keep this going as a place for us to learn from each other. So this is that. So if you can fill it out, you just have to click in the buttons, and when you have them all done, the submit button should turn blue at the end. The last two items on this list are going to be things that are foreshadowing the presentation that is about to come. So you will learn more about those things. And Olivia will let us know when we had about 80% of everybody submitted, and then everybody can see the results of what folks said. How are we looking, Olivia?
60% right now.
All right. Are we getting closer to the 80?
We're at 76.
76, so close.
Here we just hit 80.
Perfect. All right. If you want to share the results for everybody to kind of scroll through, and you have like basically this gray tab so you can scroll through all the answers. On my screen, I'm going to scroll down to the actual answers for today. Oh, we have at least one prescriber. Vinod, is that you in the room? If not, two prescribers. Good to have you guys with us. Think about the participants who are new to an RCC. The majority of us believe that somebody who is a new participant in RCC would be coming in with high distress. And then when we thought about going forward for RCC participants being followed over time, where would we see the biggest improvement? And most of us thought that the biggest improvements would be seen in general well-being, which includes self-care, relationships, material resources, and so forth. So now we are going to have a team tell us what they found when they exactly did this kind of study. So if you can move us to the next slide, Olivia. And Kim, that's okay if it didn't work out. Hopefully you got to see the results, and we can also post them. We usually do, I think we keep them, but we can also post them on our website, the polling results, so you can at least see them. All right, so this is our exciting team. They will each introduce themselves as they're going to go along, but it's a great academic community partnership that designed and did this research project together. And I'm just going to turn over to them because they can tell you a lot better about how that process happened and what they found. So these are our pilot study awardees. I think our sixth group that we have outcome data being presented. And we're really excited to see what you guys have learned and what you have found. And I think you're going to be doing the screen sharing. Is it working out for you? I did see the screen.
Yes, Ben, I think you're teeing us up.
I've got it here. Just wanted to make sure it's the right one. All right. Hi, everyone. My name's Ben Clark, and we're all excited to share some details about our pilot project with you. So our project was called The Impact of Specific RCC Programs and Participation on Recovery Capital in the African American Community. And we are finally getting some data that we're really excited to be able to show you today. So our research team was a partnership between the University of Minnesota and the Twin Cities Recovery Project, which is a fantastic RCC or RCO in Minneapolis. And I think I just want to say one thing as a quick aside. On a personal level, I think one of the most valuable parts of being able to do this pilot project has been creating a really strong collaboration between Twin Cities Recovery Project and the University of Minnesota. And even though I'm at the university, I regularly am actually partnering with TCRP on multiple fronts, like with LaTricia on Boots on the Ground and Dan Weckman with outreach to different people, and Chris's peer recovery class. I do some neurobiology of addiction sessions. So I just wanted to first say that I think one of the really valuable things that Bettina's funding has offered us is the ability to make these really great partnerships between community members and our university. So anyway, let me move on and talk to you about our project. So obviously, we all know that there's been a huge increase in drug overdose deaths over the past 50 years. So we see this 30% increase across the board in the United States. However, this hasn't really been equal across different groups of people. So Black individuals, we actually see a 44% increase, while with white populations, we see a 22% increase. And then in addition to that, we also see some other differences, such as the rates are highest among Black males. So past treatment rates are very different, because white individuals seem to seek and go to treatment with about a 16.4% rate, whereas the Black community is at an 8.3%. I'm going to stop this for 1 second because so one of the things that we really wanted to do was to make sure that what we had, that our community, sorry about this.
So Ben, it's the TCRP final present 3.8. That's the file. If you don't have it, I can share it.
I do have it now, but that one did not look like it was the one that Sheila gave me this morning, so I apologize for that. So one of the things that we wanted to do is we wanted to take a look and see if, particularly in these communities where there's unfortunately been an earned historical distrust with medical institutions and lack of cultural recognition for patients that use these treatment centers and hospitals, we wanted to see if an RCO, which is positioned more in a way to be part of the community and to actually know the community's needs and be located within that community, might be able to have a better outcome for these groups. And maybe we see some of those treatment disparities. Maybe we can actually help to build on that through RCOs, where we see that difference from the 16% of the white population who seek treatment versus the 8% in the African-American population. And then right now I will hand it over to LaTricia and Chris Burks to actually talk a little bit about the specific programs that are offered through Twin Cities Recovery Project.
Thank you, Ben. Good morning, everybody. My name is LaTricia. I am the co-founder and CEO of Twin Cities Recovery Project. Twin Cities Recovery Project is a recovery community organization that provides. Wait, say it again. Oh, that provides recovery support services to individuals who are seeking recovery. We are a culturally specific organization with a focus of on the African-American community. However, we do service everyone, and we have a really huge, diverse staff. Our mission here at Twin Cities Recovery Project is to offer assistance and support those suffering from substance use disorder in their transition towards a lifestyle of health and productivity, by offering a drug-free environment as well as resources to develop holistic recovery. This will enable them to build healthy and positive relationships and to become positive members of society. Twin Cities Recovery Project is now 7 years old. It was founded by myself and Mark Jonigan in November of 2016. We first started off as Twin Cities Recovery Social Club, where we had a space at a church here called ICCM Life Center. And so the pastor there, Pastor Monica, allowed us to use the basement of her church to start our social club. And we had live DJ, dominoes, spades. We had a concession stand, so everything that will make you feel like you in a comfortable space full of individuals who share the same experience as you had. And so in that space, we quickly grew where we were having up to 100 individuals a weekend coming to have fun in a sober environment. Next slide. In 2021, I became the acting CEO due to losing Mark Jonigan in a car accident. I have been in my role almost going on 2 years now as acting CEO, and just taking the organization to the next level and continuing his legacy. Here's some slides, some pictures here from our social club, where individuals would come into the space to have fun on Friday or Saturday nights. We would even turn some of those nights into speaker jams. We would have birthday parties for individuals who had actually never had a birthday party, and I was quite amazed by that, because we found out that a lot of individuals had started off in their addiction in their early teens. And had never had a birthday party to celebrate. And so we would have birthday parties and clean time parties. And so it was just a lot of fun with people in recovery. Next slide. And so here we are now as Twin Cities Recovery Project. We have a lot of things going on. So a lot of things that we tried to do, and here's Mark doing a number of them, is building relationship in the communities at state and federal levels. And so that we were able to let the world know that we were here as a Black RCO. Here's some of the things that we're doing now in the community as well, and it continuing to be out here, boots on the ground, and building those relationships. And so we do have a partnership with the Minneapolis Fire Department, where we offer services to individuals who suffer from opioid disorder. We also participate in the Walk for Recovery every year. And I just hosted a listening session for opioids and substance use disorder, and how it affects the African American community. So there is the panel of individuals that was on the panel, and so we used every individual, and on this panel, well, no, I'm sorry, not every individual, but several individuals on this panel are persons with lived experience and professionals in the field. So leadership from the government level to doctors at our county hospitals and the rest of the community. Next slide. So I'll let you, Christopher, come in and tell you a little more about the programs that Twin Cities Recovery Project offers.
Good morning, everyone. My name is Christopher Burks. I am a person in long-term recovery, and what that means is this June I celebrate 4 years clean and sober. So with that being said, I'll start with our programs and tell you guys something about them. One of the main programs that we do at TCRP is peer recovery support. So peer recovery support is very important, is because once a person gets clean and sober, this allows them to be able to support themselves. So we have to remember, a lot of people, that's one of the barriers why they don't get clean and sober, is because what's it look like if I do get clean and sober and I can't support myself? Where am I going to work? What kind of education do I have? So this allows a person to have their, lived experience, and they can actually, it teaches them how to help somebody else maintain their recovery. It is a week-long class. I really enjoy it. I get to facilitate that class now. The next one is our grief and trauma support program that we have. Right now, we're offering that. We have a partnership with the probation department in Hennepin County. So they refer us some of their individuals, and it's a 8-week class, and they come and they get to address some of that grief and trauma. We also have a community program where we offer it to the community. They can come back and deal with grief and trauma. We also have like a aftercare program. So after they do the 8 weeks, they can also come back, like if they want to continue to get that support. We also do HIV testing and education about what HIV is and all that different stuff. We also have a re-entry program, which is we have another partnership through the Hennepin County, and it's through probation and parole, where we actually stay in contact with individuals who are incarcerated. So we actually write back and forth with them, kind of like their last year to 6 months. And, we kind of help them out. They do have a peer support on the inside, but we're just, we're just here for them. So when they do get out, they'll have somebody they can come and we can help them deal with those barriers that they have, upon their release. We also provide vocational and occupational support. So, we help people get jobs and things of that nature. We also have an awesome community outreach team, which goes out twice a week, every Tuesday at 1 o'clock and every Friday at 10 a.m. in the morning. A lot of times we go to the encampments, we go to North Side, South Side, and we're trying to really get our outreach team. We want to get it bigger because it's a lot of areas that we do go to, but it's a lot of areas that we don't get to go to. So like the need is really great in, just the city of Minneapolis itself. So we do have substance-free social events like Ms. Tate was telling you about. We still do the social club things on the weekends and things of that nature. We have a men's support group, which is part of the probation thing with the reentry. It is a men's group. We meet every Tuesday at 5:30. And really it's a place where African-American men, especially, we welcome all men, but African-American men can come and they can just address some of the issues that life throws at us. Men really don't have that platform where they can just sit and talk and be honest. So we provide that safe place for people to be able to do that. We also have a program, Young People in Recovery. It's called ROC, Recreation of Change. And that is a 10-week cohort. And it's actually for youth from the age of 12 to 26. And they get to come and, they get to talk about what they're going through. Like we was talking about the opioid crisis that's out there now. The opioid crisis right now is really affecting the youth. A lot of the overdose deaths that have been going on has been young kids that are still in school. So like we need to address our youth. We need to educate our youth of what's going on, and we need to give them that platform so they're able to come and talk about what's going on. So the last program I'm going to talk about is the Maury Station. Ms. Tate kind of mentioned it, but the Maury Station is actually a partnership we created with the fire station. And the purpose of the Maury Station, one of the biggest, is to address the opioids, but the Maury Station also stays open 24 hours. So what that means is a person, if they want to get clean and sober, if they want to get help in the middle of the night, they will have somewhere to go. Most treatment centers or recovery community organizations, they shut down around 5 o'clock. But if you're able to go somewhere at 9, 10 o'clock at night and say you want help and somebody is there to assist you, that helps. So basically what happens is the Maury Station they will call Twin Cities Recovery Projects, and we will respond in a reasonable amount of time, and we will come and we will assess the situation. Yep, and this is a thing of our board, and that's pretty much all I got for you.
I was just going to say there's a question here from Michael in the chat. I'll ask you about the development of a workforce. Is that something that Twin Cities also does? Like training certification and so forth of peer recovery coaches, or is that not part of it?
Yes, we do have a peer recovery training class that I do facilitate. So the class is like a week long. We have one coming up in April. It's a 46-hour training, and it is free to the BIPOC community.
Awesome.
Yes.
Awesome.
Yeah, and we also have partnerships with different organizations to be able to provide employment connections with to help them. Sometimes we hire, and if we have partners that are hiring for coaches, we also forward them on to other organizations.
Awesome. And Valeria had already asked about the age, and you guys are starting at 14, which is amazing that you were able to do that. Very few RCCs are able to get young people early on to come and seek help and participate. So that's impressive that you guys are able to engage the youth in your community. Sorry, couldn't help but just jump in here with that comment. Go ahead.
Okay, so for our project, one of the things that we really looked closely at was this concept of recovery capital. which is the sum of the internal and external resources that a person has available to start and to sustain the recovery from substance use. And this is commonly divided up into multiple categories. There's a personal, a family social, a community, and a cultural. And the personal is thought of as the skill set that that person has, whether that be vocational or education background, but also the physical health, the financial assets, and if that person has health insurance or not, if they have housing, etc. The family and social capital are the person's relationships, the family, friends, and people who can support them during recovery. And this can include things like schools or churches. The community capital is the general attitudes, the stigma that might be prevalent in that community or not, the policies and the resources that are available to help people with their recovery. And then finally, the cultural are the pathways of recovery and community resources that resonate with the individuals and families of different cultural backgrounds and different faiths potentially. One of the key takeaways here that I want to kind of point out is that all of these different categories mirror really well what RCOs provide the people that are visiting them, much more than, say, what a clinic or a treatment center would be able to offer. The RCC is really positioned well to provide increases in these recovery capital categories. So there has been some previous research obviously done on recovery capital. A lot of it was done by Bettina and John Kelly, actually, where they have looked at recovery RCCs and recovery capital. Some of the things that have been identified are, so in one particular review by Tracy and Wallace, they pointed out that there's a positive effect of peer support in not only reducing substance use, but also improving engagement with treatment centers and other parts of a person's recovery. And then Bettina has done 2 really great studies looking at RCCs and how they impact recovery, and also looking even closer into recovery capital. One of which back in 2020, where they looked at multiple RCCs in the Northeast and looked at how, if they could correlate engagement with any sort of an increase in, say, quality of life or increased in recovery success. And then another one in 2021 that was actually a longitudinal study where they saw that there were improvements in the duration of abstinence and substance problems and also quality of life, but interestingly not in recovery assets in that particular study, if I'm not mistaken, Bettina.
No, yes, that's correct. So on recovery capital, we didn't see that increase. And also just to clarify, John was the one who was the principal investigator on that. I was involved in the study, but
oh, sorry,
he was the one leading it, both of us.
So the project goals that we had is that we wanted to take a look at TCRP's programs and services and see if they would impact recovery capital, and then also determine if there was an increase, if it was associated with successful recovery and increased well-being. And then finally, we wanted to look and see if there are any barriers that we could have improved upon that might continue participation or engagement with Twin Cities Recovery Project. And now I will hand it over to David to describe our study design.
Okay. Thanks, Ben. So our basic inclusion and exclusion criteria, we were looking at people over 18 years of age for the purpose of this study, even though there are, as we said, a younger age bracket in that facility. They were voluntarily seeking services at Twin Cities Recovery Project, TCRP. They had to have at least working proficiency in English. We debated on having, translated documents. We figured for simplicity at this point to do that as a baseline. And we decided to focus on people who were relatively newly coming into the program. So they had to have been entered within the last 30 days. Didn't mean that they automatically were in the same stage of recovery, but they were entering TCRP at least within that 30-day period. And so as mentioned before, that first month we would capture them and get them assigned. As standard practice, they are often assigned a recovery coach at TCRP who tracks them and keeps in touch with them during their time in that organization. So that was kind of the contact point. And then they would be everyone would be given a brochure and explaining the project and study design and give them, time to ask questions. And And then if they agreed, they would be given an information sheet and an iPad to do an online survey. And we would get demographic information, a substance use history in the last month, and then do a series of 3 different surveys, which I'll outline in a minute. We did this at baseline to get a sense of kind of where they were when they were coming in. And then at 3 months, we did a follow-up of essentially the same battery of tests. And then we did give some compensation for this for their time. We gave CLIN cards at the baseline and then for doing the 3-month follow-up. In addition, which was really nice, is because they had that relationship with the recovery coaches, they would basically check in with them every week as part of their standard practice. So during those check-ins, they also were kind enough to enter into our system like the services that were received during that week, as well as any substances that were used, to give us a little bit more kind of on-the-ground data. So the 3 tools we decided on, we didn't want to overwhelm people, so we kind of decided to go with 3 main ones. The first, and I'll go through these on the next slides in a little more detail, was the assessment of recovery capital, which is trying to measure recovery capital, the substance use recovery evaluator, and the Kessler psychological distress scale. Just of note here, we actually used a self-report K6 plus scale, which is a 6-question one, not the K10, just to clarify. So the ARC, or the Assessment of Recovery Capital Scale, is a yes-no survey of 50 questions, trying to assess, as it says, recovery capital. And it breaks down into main 4 categories. I put some example questions here just to look at if people wish, but the idea is just kind of capturing, do they have a sense of purpose in life? Are they able to concentrate when they need to? Can they cope with their current stressors? These kind of concepts here. So it's not just about are they sober, it's also these other important aspects that can lead into sustained recovery, we think. And then the SURE, or the Substance Use Recovery Evaluator, measures a person's recovery and how it's going. It was designed with the help of service users, so hopefully we can capture what's really important to them, people in recovery. For our analysis and data that we're going to report later, we focused on section B, as I'll go through this in a second. But we did collect all of the sections during the baseline and 3-month follow-up, and we'll see if there's any other patterns that we want to look at. But section A looks more at like substance use focus, but since we captured that in other areas, we're not focused on that now. Section B was more about self-care, relationships, material resources, and outlook on life. So kind of how they related those. And then section C isn't actually scored in the survey. That's how it's set up, but it does at least let people comment upon what's most important to them in terms of those above domains. So it can give a sense on where that person is at in terms of what they think is most important. And then we can see if there's any patterns there in their scoring. The Kessler 6 scale, the self-report we used, assesses overall well-being and the level of psychological distress is kind of what we're trying to assess there. It's a pretty well standardized instrument. And it looks at things like nervousness and depression, how much they're experiencing these. So I'll pass this on, I think, to Sheila and Steve for the results discussion.
Okay, well, thank you very much. So I am Sheila Specker, and I'm an addiction psychiatrist, an educator, a clinician, and researcher at the University of Minnesota. And Dr. Steve Thurber, who's also on this call, is our psychologist statistician for this. And I also wanted to mention Dr. Ese Agente, who's helped with the development of this whole process, who is one of our addiction medicine physician fellows with the project. So what I'm going to present is essentially an interim analysis. So we have 2 populations. So we have 64 individuals who started the project over a year and some ago, and we will have another 22 individuals who started this year that are not yet at our 3-month follow-up period. So I'm going to be commenting more on the group differences in our first initial cohort of 64. So about 2/3 of this group were male. And as you can see down here in terms of relationship status, most were single. Average mean age was 43, so it isn't a younger group, although this does bring up the question about, yes, really addressing some of the younger group is going to be really important. In terms of income levels, as you can see that almost 80% had an income level of less than $14,000 annually. Next slide. the demographics. Okay, so what is the population? And as we know, the target is the BIPOC underserved population. And so about 2/3 were African American, Black, and 16% white. And then you can see the other distribution. Next slide. So education. So as you can see, about 1/4 of the group had less than a high school education. High school diploma, GED, and some college, as well as some post-college. But some of the challenges, I think, in the group really had to do with education, and as we'll see, living situation and work. Next slide. So the living situation. The top 3 bars are various forms of homelessness. You look down, alone in own home, I think more refers to not necessarily having a stable home, but at the moment having a place that they are able to be for the moment. Next slide. What were their goals? So one of the things that we were tracking is how they met goals. This is specific to their substance use. So as you can see, people coming into the program, abstinence was by far and away the goal. Now we know, I think we all realize that abstinence is certainly not the only measure. Recovery is much more encompassing than solely abstinence. But this particular cohort has identified as absolutely that is a key priority, and a certain segment reducing use. What I was surprised at was the small group that were looking to obtain medication. And given that opioids are such a problem, and one goal is to get people connected with the medications that they might need, such as buprenorphine or methadone, I was surprised that that was not really the case. But you'll see on the next slide probably why. Accessing recovery services, that clearly was a goal, and that was what I think sparked interest in TCRP. Next. How did you hear about TCRP? So there's a variety of ways, and any of you TCRP staff, LaTricia, want to join in and comment about how people get into a program, that would be great. Treatment centers that get referrals from all over. But other kind of took me by surprise. How do people get there? Word of mouth, social media. I think TCRP, even though starting in 2016, has a well-respected, well-known reputation in the Twin Cities area. LaTricia, any comments you'd like to make about how people get into TCRP?
Yes, I'll say what you guys already have it here. A lot of times, our staff, a part of outreach that we do is going into treatment centers and doing presentations, going into different clinics, going into, we have a partnership with, oh, Christopher, what is the name of it for?
For housing?
No, housing and other places, HCMC, different places like that. So we do go out to those different places and build relationship and leave our information there. We just went to Fairview Hospital emergency room a couple weeks ago and took our information there so that they could bring people to us. So figuring out different ways to get people into the organization is what we do. And so that's how a lot of times people find out about us. We just, one of the other things we just did last week is we purchased and created postcards, and we sent them out to community members in the mail. And so that's another way to gain access to individuals. And so we just constantly thinking of ways to do outreach and bring people into the organization.
Right.
We
Yes.
also go to the encampments.
Yes.
So I go to encampments. The outreach coordinator with TCRP, we go to encampments on Tuesdays and Wednesday afternoons. And while we're passing out harm reduction supplies, we also pass out flyers for TCRP.
Right.
Yes, we've had several people come to the building, even like months later, with one of the cards or flyers that we have passed out in encampments, and tell us, they're ready to get in treatment. Another place where we get a lot of people from is resource fairs. So anytime just kind of like a resource fair anywhere, we try to attend that, and that's another way we get the word out of who we are.
Right. Thank you. I think the outreach is huge and always looking for opportunities. I've been involved also with the SAFE project. And even if people don't come to the fire station, it's all the outreach work that happens to get people in. Okay.
Another way that we do it too, though, believe it or not, is just the t-shirts. So I've had plenty of people ask me, I see your t-shirt, I like it, what is it, and you tell them what it's about, and they'll come and check us out.
I think t-shirts are a great idea. I'm in a hospital, so I okay. Thanks, Christopher. Okay.
A
Next.
pin or something like that could work.
Yeah, right.
A button.
We're game for any of that. Okay, so what services are desired? Okay, so this is part of our recovery capital assessment. What services do people want? Obviously, it makes sense. Recovery coaching. People come in, they're assigned a coach, and they work with that person. And our project was, as David had mentioned, is the coach meeting weekly, having that opportunity to meet with the coach every week. Housing, recovery groups are really the top three. And then you'll also see employment, social club activities, grief and trauma being huge. And this whole range of other services that people are interested in. Okay.
Just a quick note about time. We have about 11 minutes left until most people will log off. We will have a half hour of discussion afterwards, but just to be mindful that Julie and Maryanne also wanted to still weigh in and comment at the end.
Thank you very much. Okay, substance. So alcohol, interestingly enough, was really the primary substance, the largest indicated problematic substance. And the opioids being very low, which kind of took me by surprise, which probably is why seeking medications perhaps was not high on that list. I also was surprised that there were individuals that came and said, oh no, substances aren't necessarily my big thing. But I think also that was part of their history. But at the moment when they were seeking help, whether that be to maintain sobriety and to address all those other factors that need to be there in order to sustain recovery. Okay, next. Okay, so at 3 months, and again, this is interim analysis. We're comparing baseline with 3 months. So it's group comparisons. We don't have the individual comparisons yet. So this is the first draft. 64 completed the baseline and 45 completed the 3-month follow-up. We have 7 that have continued past the 3 months right now, and we're projecting to continue that. And then we have another 22, or we have 22 that have completed at least 75% of the weekly visits. So I see that as a measure of engagement. So half of those that completed 3 months had more than 75% of the visits. Okay, so when we look at changes in terms of substance use from baseline to 3-month follow-up, you can see the reductions of use, and these are group means, just to keep that in mind. We'll later be able to do individual comparisons. And never mind the data irregularities, which was a great way of putting red cap is a problem. So we'll get there.
It's usually great.
Yes, okay, so there was that. Our 3 instruments. Okay, so our Kessler instrument, which measure of distress, as David described. We didn't see a difference in this. So this was a common, most people would, at the beginning, and the poll said high levels of distress at the beginning and improvement later on. We weren't seeing that, which was kind of surprised. People coming in may not have been in acute position of stress. They might have been in a treatment center. They might already, kind of be starting their recovery journey. But again, this is a group comparison. So we will have much more to say about this later. Next slide. Okay, so when we look at the ARC though, so this was our main measure, assessment of recovery capital. This was a 50-item yes, no. All these variety of internal, external measures or items having to do with recovery capital. And this clearly did show an improvement from baseline to 3 months. So the services that people received, the connections, and I guess I just really want to emphasize, I think the connections with people are so critical. Yes, it's the services, but I think it's also the engagement that happens. Next slide. Now, this is the other instrument, recovery evaluator, that had also some general questions about self-care and relationships and so forth. And we, on this particular section of the instrument, we're not seeing any significant change from baseline to 3 months. But again, this isn't the final story either. When we look at meeting goal, okay, this is goal with regard to their substance use. Were they able to stay abstinent? Were they mostly able to stay abstinent or meet their goal? And you can see the high rates of mostly or completely meeting goal in regard to their substance use. So I thought that was very encouraging. And this is at 3 months, and recognizing that not all changes can happen. That's a really pretty short time period of 3 months. So we were really encouraged by this. So thus far, what we can conclude is that there really was a high engagement rate. And that, I think, has a lot to say about the relationships of the staff, of the TCRP staff and the participants. Recovery coaching, housing, those were key needs that were identified. And recovery support groups, grief groups, I think Christopher commented about some of that. Employment, the social club, there was a very high desire for abstinence in this group. And then one of the measures, the ARC, which we used as our main measure, there was a significant increase in recovery capital, even over this short 3-month period of time. So where we're going is to obviously incorporate these additional 22 that have begun, finish our analysis, look at individual differences, extend the survey to 6 months. We won't be able to, I'm sure, incorporate everyone, but we want to get as much information as we can. And looking at roadblocks and obstacles, I don't have much to say about that yet. TCRP may be able to say something, but I'd also add, just as we were talking about youth, how important that is. And the substance use patterns are different for youth. There's more opioids, more overdoses. There's other opportunities in the community, working with EMS, for instance, and connecting in the on-site where overdoses happen, getting connected after a reversal. So I'm going to stop there. I think there's probably questions or other thoughts or suggestions for us of areas that we want to focus on.
Yes, thank you. I was going to ask Julie and Maryanne to weigh in. They are doing, and I'll let you speak to yourself. We invited you to comment on your gut reaction and takeaway from the science you've just seen and the work that was done. You guys influence policy in the recovery world. You work with a lot of RCCs. When you see these data, when you see this project, what are your gut reactions and thoughts? You're muted, Maryanne, by the way.
Must always unmute. Great. No, I am Maryanne Frangules, and I am a person in long-term recovery. I am also the executive director of MORE, the Massachusetts Organization for Addiction Recovery. It's a statewide organization of people in recovery, families and friends for educating the public about the value of living in recovery. And it's wonderful to be here to witness all the great work that you have done with Twin Cities, and also hearing about the Healing House, and the studies with the facts, the stats, and the stories, and doing advocacy. That's always something that policymakers respond to, is wanting to see like living proof that something works, and then having a nice fact sheet, and then people that can be able to share that this is so important. And I want to, I'll ask some questions, but I want to turn it over to Julie, because I think you have some time constraints.
Yes, I do. Thank you, Maryanne, and thank you everyone else for including me in this. This is very interesting. I do have I have two questions. One, I would like to know, like, yes, the recovery capital, and how many you took data regarding abstinence, non-abstinence, but in the beginning, like, did you take information on what other goals that they might wanted to, perceive, or, go on to that? Because there's other goals that they could have, been successful at.
Absolutely.
So some of that was captured, I think, by the asking what services they wanted to access. It's kind of how we thought. If they were looking for housing or employment, that was kind of the idea there. But otherwise, no, we didn't do a specific goal setting as a separate instrument besides just what services they were looking for.
Okay. And the reason I asked that question is only because, I know in the recovery, not everybody's looking for abstinence. So that's the only reason I do ask that question. And did you measure also, you talked about like the BIPOC community, Indigenous, did you cue in on what special services they might have needed?
So we have not yet separated out the group, and that's why I think this is good timing for us to present, to get your ideas about how we would like to further divide up the analysis. So 80% of the group is Black African American, and 20% is white. We have a smaller portion of other individuals, BIPOC, but absolutely. And we'll have enough numbers with the addition of, I think, the 22 that we will have, that we will be able to divide up the group and look at more than just group differences as a whole.
And then, of course, because I work for I work in advocacy, it might be interesting to know how many would like to be involved in advocacy, how they get involved in advocacy, and do they know that their voices do matter?
Yeah, absolutely. I mean, I think TCRP, if you would like to make a comment about that.
Absolutely, I can answer that. Here at Twin Cities Recovery Project, we offer all of our participants to be a part of different listening sessions and focus groups if they would like to. I always encourage them to, even if they don't want to speak, to sit there and listen, because the next one, they might have something to say. So we're always including them and engaging them in any and everything that we do in the community, because we want to know, because we know that and I say this to my team all the time, we don't want to give anything to our community, to our participants, that is about us. We need to ask them, what do they want? And so we always include them. We have surveys, little questionnaires here at the building, and allow them to fill those out and leave them for us. Or sometimes they just tell us. We also have a social, we have a committee built up of the community for our social wellness program, and they plan our events because they know what the community wants. So that's kind of how we do it.
Thank you for that. Thank you.
Right.
I see Corey's comment or question, next steps. would like to know which domains of recovery capital increased. Absolutely. So we have the total, but there are sub domains. I totally agree. That would be a next step.
Right. And I'm wondering, and LaTricia, if indeed, if you were to offer some words of wisdom about your own process of building the Twin City Recovery Center, and how would you encourage other people to do this? What was it like for you? And then what was it like for you to engage with scientists?
Okay, so I'll just say, so I didn't do this alone. Mark Jonigan was my fiance, the person in long-term recovery, and he started this was his brand, right? And so we did it together. One of the things that we knew that we had to do in building this brand was reach out to all the greats that had done it before us, right? And so as we started to continue to grow, we reached out to different organizations. So Andre Johnson in Detroit, he has always supported us and pushed us to be our best selves, right? And then we started to connect with other individuals as we started to evolve and continue to grow. So people like Phil Rutherford, people like Dr. Corey. So we know how to, we started to engage with those individuals to help us understand like how to move forward. And so just understanding that we don't know it all. And if we want to be great at what we do, we have to secure ourselves with people who have already done it. And so that's what we have done. And that's what I continue to do. And so I have Miss Dora in Chicago. I have Andre in Detroit. So I reach out to everybody to have my back. Working with scientists has been incredibly fun. Dr. Ben is now on our team. He does outreach. Like he said, he does everything with us now. I learned a lot from him and Dr. Mark Thomas. And I love Dr. Corey. She makes, and I said this to her before, she makes learning science fun, right? And so just listening and learning has been an incredible experience for me. And I just love it. It's been great.
Wow. Well, that's wonderful. You explained that so very well, like searching for mentors. Who's done this before us? Who looks like me? Who can encourage us? What did they use? What was their formula? And then going to the scientists is like, oh, wow, you're fun people. You're going to help us make this work.
Absolutely.
That's fantastic. That's fantastic. And a question for the scientists. The other day, in speaking about your reward system of people, if you supply this information and you come back in 2 months, you come back in 4 months, and then you get, some kind of reward. And I mentioned how in Massachusetts, because we do advocacy, we're learning about the value of contingency management to be able to offer that incentive to people that need help where there is no medication to support them coming in with a stimulant disorder. And then Bettina, you shared about another phrase that was brand new to me. And so I was wondering, how is it that we use incentives and what are the different ways of doing and how are they categorized?
But I guess I'll weigh in there. The challenge here is that when we want to do science, we want to respect the time people take. Like whenever we collect data or whenever we design a study, people are taking time out of their lives to create the measures to administer them. And people are taking time out of their lives to answer those questions. For all of that extra time that goes into creating that, we want to make sure people are compensated for that. They can get paid for taking their time because otherwise it's an unreasonable ask and a burden. So that's why we do that. Typically, in a science study, we don't want to pay people to say, go talk to a recovery coach or to take care in a therapeutic engagement, because then that influences being paid to do it, influences whether or not they're going to do it. And it's supposed to be a test of them choosing to do it and what that impact is on them. So that's how we try to differentiate between, if you fill out a survey about the recovery coaching you had, we can pay for their time, but actually going to see the recovery coach is not something you would want to pay for in a research study, so you can keep those things separate.
And
Contingency
also,
management, of course, sorry, Sheila, go ahead.
yes, and also the amount of the compensation too is something that we talk about all the time. You need to, we want to compensate them fairly for their time, but it's not like we're going to, pay them $1,000 either. So in this particular project, I believe the initial baseline questionnaires was $25. At 3 months, it was $50. And then that provides some incentive to, get back and do those questionnaires. And then at 6 months, it'll be $50 as well. So that provides enough of an incentive, and yet it's not every week that they come in. That would be more contingency.
We were a little nervous about using the ARC instead of the brief one that Dr. Corey Vilsant created, I believe, because it did have 50 questions on it. We kind of boosted the level of the amount that we were giving back to the person for filling out the survey, so that got pushed up a little bit.
And it's not unusual that we compensate people a little more towards the end.
So there's such a value in being, like you use the term compensation, you're going to provide something for us. This is a little bit of a reward or a lot of a reward. And then they have a menu. It's like you're looking ahead. If I do this, I will get this. If I do this, and then along the way, they're building their skills, which is really, really wonderful in a very positive way. Wow. And in speaking of this, I'm hearing so much about connection, and I see that in the now 39 recovery support centers in Massachusetts, and the value of it. And I see the value of the recovery coaching and making connection. And you described really great ways to be able to measure. I'm wondering about the value of recovery coaching, and the outreach, as you mentioned, is something that's all near and dear to us, as you said, the encampment areas where the major amount of marginalized populations are. So has recovery coaching been used for that? Is it like a wise thing to do? What's been your experience?
Yes. So
and that's about outreach.
Yes. So going to encampments is a huge part of our outreach. I would be comfortable saying for my team and Dr. Ben that we love outreach at the encampments. Making those connections is important. And all of our outreach individuals are peer recovery coaches. And so when they go out there, they're able to give information, build relationships. Like Chris said, if they don't take it then, they do show up eventually with this card or whatever and say, I met you at outreach and I want to coach.
And
so
a couple times too, like a couple, I mean, after the first time we just kind of hand stuff out, say, hi, this is who I am, but we see the same people week after week after week. And then over the course of like 3 weeks, then they open up more and more as we, commit to going back there all the time.
Which is all part of the study. That's wonderful. Thank you. Thank you very much.
I'm going to ask Olivia to stop recording just because I